My name is Praveen Pedu. I'm an interventional radiologist at King's College Hospital in London, and I have an expertise in hepatobiliary interventions. My main field of work includes oncology, which is treating a lot of liver tumors and also pancreatic tumors occasionally. So in my practice, I tend to treat a lot of liver tumors, and these include both primary liver tumors and also, metastatic liver tumors. Metastases can be from bowel or also from neuroendocrine tumors. Those are the main sorts of patients I deal with in my practice. And I would say majority of the patients, we do a procedure called microwave ablation, which is a thermal ablation and well established. But there are certain groups of patients where the tumors anatomically are located in a challenging position. For example, tumors in a central location in the liver, next to a major bile duct, or next to a major portal vasculature or hepatic venous vasculature, where you're concerned about causing complications, because you're not only damaging the tumor, you might also damage the structure next to it. So in those situations where we tend to use IRE quite frequently, but the actual technology is called IRE, irreversible earth reparation. So IRE is and still remains a novel technology because it works slightly different to other forms of ablation. In IRE, what we tend to do is we bracket the tumor with multiple needles, and the needle number could be between 2 to 6 needles. And what we tend to do is we create a high voltage electric field in between those needles to ensure that we damage the tumor. And the tumor damage occurs at a cellular level. So these high voltage electric pulses, what they tend to do is they tend to produce nanopores in the cell membrane. That's why it's called NanoKnife. And that causes cellular damage, and cellular damage occurs, and then there will be cell death and apoptosis. In King's, we started using NanoKnife or IRE in 2014. That's when we first started using it. So it's literal over 12 years now. We have a vast experience using IRE, predominantly for liver tumors. We also use it occasionally for pancreatic tumors as well. In the liver tumors, as I explained, we still use microwave as a predominant ablation technology, but we use IRE in places where we cannot use microwave. When it comes to pancreatic tumors, we started using IRE for locally advanced pancreatic tumors, but over the last sort of 5-6 years, the practice has shifted with the use with now the stereotactic radiotherapy coming into play. We tend to see a lot of patients going that way rather than coming for IRE. The other cohort of patients where we tend to use IRE is for borderline resectable pancreatic tumors, meaning tumors which are just about resectable, and there is a chance that when they get resected, they have positive resection margins, meaning some of the tumor is left behind in the patient. In those situations, we tend to do an intraoperative IRE to ensure that we treat those margins before the tumor is being removed. So that means that there is a higher chance that these patients will have negative resection margins, meaning there's no tumor left behind, which then impacts on the outcome. So it means those patients tend to survive longer once you ensure that those margins are clear. In my practice, having done over 200 ablations with IRE so far, I would say the results I get are similar to what I would expect to get from a microwave ablation. So they're pretty good actually. So the outcomes, meaning having less number of complications from multiple needle positions, as well as ensuring we get complete ablations, is significantly better. So there is some research going on as to how we could use a NanoKnife in conjunction with systemic immunotherapy. So there is some research going on both for liver tumors and also predominantly for pancreatic tumors. It's particularly more exciting in the field of pancreatic tumors because pancreatic tumors are usually very chemo-resistant, and the systemic therapy options are very limited and they do not respond well. And that's probably because they're called cold tumors. They're not very active receptive tumors. By using IRE, we can actually stimulate the tumor, make the tumor hot, meaning make the tumor more immunosensitive. So prime the tumor. So combining IRE with immunotherapy tends to produce better results. At least that's the understanding of it. There's still active research going on in that field, but I think that's where the field is moving, particularly using combination therapies, particularly in the field of pancreatic cancer.